We are here to briefly discuss our recently published manuscript in the American Journal of Rheumatology entitled CT Attenuation Values Do Not Reliably Distinguish Benign Sclerotic Bone Lesions from Osteoblastic Metastases in Patients Undergoing Bone Biopsy. My name is Garner, and I am a musculoskeletal radiologist at the Mayo Clinic in Florida, and I am the second and corresponding author on this paper. And with me is Dr. Antoine Azar, one of our excellent second-year residents, who is first author of this paper. As an introduction, my co-authors and I embarked on this research project because we had noticed that some of our colleagues were applying the previously published CT attenuation values that were intended to discriminate bone islands from osteoblastic metastases to any indeterminate sclerotic bone lesion. We were concerned with this broad application of these CT attenuation thresholds because in our experience we have appreciated that some osteoblastic metastases as well as other malignant sclerotic lesions have attenuation, very high attenuation values on CT even when they're not previously treated.
Therefore, we wanted to answer the question, could these CT attenuation values be more broadly applied to any indeterminate sclerotic bone lesion seen on CT? We decided that the best way to define an indeterminate sclerotic bone lesion in a database search would be to search for lesions that ultimately were biopsied. So after doing our retrospective searches and excluding lesions that were not truly sclerotic upon our review, or that did not have a pathology result, or that had a non-diagnostic biopsy result, we ended up with 280 lesions and 280 unique patients to investigate.
One of our other co-authors, Nick Rhodes, and I separately measured the CT attenuation values in each of the 280 bone lesions, and we had an excellent inter-reader agreement. When we applied the previously published CT attenuation values to these lesions, we found that both the sensitivities and the accuracies were low for both the average and maximum CT attenuation thresholds. And furthermore, the receiver operating curve analysis showed that there was no alternate high-performing threshold to discriminate benign from malignant.
So our results show that the previously published CT attenuation thresholds could not be applied more broadly to any indeterminate sclerotic bone lesion seen on CT. These CT attenuation values were derived purely to distinguish between enostoses and osteoblastic metastases. The CT attenuation thresholds should not be used to distinguish benignity from malignancy in any sclerotic bone lesion seen on CT. Clinical history and patient age and imaging characteristics should always be taken into consideration when making determinations as to these lesions.
Thank you so much for watching our video. We appreciate your time. If you have any questions about our project, please feel free to email me at garner.hillary@mayo.edu. Thank you again so much and stay safe.